Hi, good morning, everyone. Welcome to our Unit 4 discussion. Hopefully you guys are all doing well. I've heard a lot of feedback and emails from you guys that are sick, and I think there's a lot of stuff going around, so hopefully it's not hitting you too hard. My kids have been sick too, so hang in there. We're halfway done, okay? So our Unit 4 discussions on information technology and surgical services. So our objectives for today are going to be understanding how technology works in the healthcare and how it pertains to patient safety, privacy, again, the HIPAA laws, and how we as surg techs can utilize this type of technology for, managing our patient care. So our assignments for this week include, again, the discussion post, a couple Realize It's, and then another Unit 4 assignment. So be sure with your Unit 4 discussions, notice it's 40 points, it's the majority of your points for the week, that you need to be submitting them on Wednesday, your initial post, and then submitting your peer responses by Sunday. Remember, you need 2 peer responses for full credit. Okay, some of you are only doing 1. And be sure to check if I've made previous comments from the first couple weeks that you have made discussion posts. I'll put comments below on things that you need to work on or whatever. Be sure you're going back and checking those so you can make those adjustments so you don't get, the same points taken off every time, okay? You don't need to be uploading like Word document files. Just type it directly into that text box for me. That way I don't have to download a file and potentially risk like a virus or something like that. That way it's just right there. It's easier for me to grade and I can use the rubric right there, okay? And then also make sure you're citing your sources. You have to use sources and they have to be cited in APA format, okay? So those are typically where most of you are getting points taken off, and it is for a good portion of your weekly grade. So go back and double check those, okay? All right, so how are we going to use information and like diagnostic procedures? So a lot of people are like, I thought surg techs just pass instruments. We're just in charge of sterility. Why do we need to know things about like diagnostic imaging or tools or computers? So how does that pertain to me as a surg tech? So we are considered members of the operating team, right? We're a part of a big group. Surg techs have to know a lot of people's jobs, so to speak, even though we don't do their job. We have to be aware of everything that's happening in the operating room, okay? That way we can, we're all there to, for the patient, right? We're all there to make sure the patient has a good outcome. So if we can, better our knowledge of what's happening surrounding us within the OR, with what's going to be happening to our patient, we can obviously provide better patient care, okay? So part of that is understanding those diagnostic tools and imaging techniques, et cetera, that we're going to be talking about. That way we can adjust what we need to do to prepare, okay? So a couple diagnostic procedures we're going to talk about today. We're going to go into a little bit more detail into some of them. You're going to have a couple of videos to demonstrate what those might look like if you're not familiar with diagnostic procedures, okay? So one term is endoscopic. So if you break that term down, if you go back to your med term, you have that term endo and then scop and then ic, right? So I see at the end that suffix there means pertaining to, endo is within, and the scope is to view. So it's pertaining to viewing inside the body. So we can do that in a lot of ways. Typically, it's through some sort of scope. We call it an endoscope. Sometimes it's named after the type of scope that you're in the body area that you're working in, like the abdomen would be a laparoscope. If you're going in to view the stomach, it'd be a gastroscope. So it could be named after wherever you're working. That is used for diagnosis. A diagnosis is a term that we use for like getting an entire picture or what is happening with the patient is really what that means, okay? The doctor is trying to get a diagnosis of what is happening inside that patient, what's the outcome. We can determine a lot of things by a diagnosis, okay? So these are ways in which we can do that. Imaging studies is another one. It's kind of a broad term that includes things like X-ray or a CT, MRI, things that provide a picture, an actual visual picture of what either is happening inside the body or what it looks like inside the body. Another example, basically, of an imaging study is fluoroscopy. We'll break these down here in a few. Fluoroscopy is a really cool technique that uses something like an X-ray to provide a real-time image. So the X-ray technician can like step on the foot pedal or press a button and the picture goes live. So you can see things moving in the body. You can see how things are flowing. It's really cool. Okay. The next one is a Doppler study. This is used to like uses sound waves, like, and the image will come back to make a picture based on those sound waves, which is kind of crazy, in my opinion, ultrasonic waves. So it's really good for measuring like flow of something through a vessel, especially blood flow. We're trying to see if there's blood flow to an extremity, making sure, you know, the flow of blood hasn't been cut off in some way. We could use a Doppler. The next one is a biopsy. We'll break these types of biopsies down here later, but a biopsy is just taking some sort of tissue sample in a variety of ways to be examined microscopically. We can see a lot by looking at the cells under a microscope. We can get a good diagnosis that way, which is then going to obviously change, you know, the course of the procedure or the patient outcome. So two other terms here pertaining to diagnosis. We can talk about it in these two ways, invasive and non-invasive. So an invasive diagnostic procedure is going to be one that cuts through the skin. Essentially, you're penetrating the skin or even like a mucous membrane, the nose or whatever, to insert a medical device. That way, you know, you're going deep. You got to find a better picture than what you can see on the outside. So non-invasive techniques use, like, you're not cutting into the skin, you'll not go into a mucous membrane, there will be no blood, okay? So things that happen like maybe directly on the skin or even like an X-ray is non-invasive. You don't even touch the skin in that instance. So limited or no direct body contact. So the relationship between pathology and diagnoses, that term diagnoses is plural, okay? Just for your information. Why do we as surg techs need to understand pathology and diagnoses? Why do we need to know this? We're not doctors, right? We're not making the diagnosis, but we are participating in the process. So that means we might be part of surgical procedures that are using one of those diagnostic tools we just talked about, whether invasive or non-invasive. We use things like X-ray, CT, fluoroscopy, even though they're non-invasive, directly inside the operating room. And what they find during that diagnosis, whatever the surgeon says there, will change what happens in the procedure, okay? Sometimes they will even come in and put like an X-ray on a screen or on the box that lights up. If your place still has those, they're kind of old school, but they'll put those up there prior to the procedure. And then you can look at those and say, okay, well, this bone is obviously broken. Here's what I need for this procedure. No, we're not necessarily making that diagnosis, but it does allow us to better plan for those surgical procedures. Or your surgeon may pull it up and even say, okay, I noticed this, you know, fracture here on the 5th metatarsal. Okay, so in your brain, you need to know, you need to know your anatomy and how it pertains to the surgical procedure, but the pathology here that it's broken means you're going to need a specific set of instruments, or maybe with that procedure, your surgeon needs a specific, you know, drill, whatever it is, okay? That's going to come with time. It takes, you know, quite a long time for a surgical technologist to be comfortable enough with, you know, understanding that anticipation, okay? Anticipating surgeons' needs is a huge part of being a surg tech, but it also takes quite a bit of time and practice. So you'll get there. So don't feel frustrated when you like start clinicals and you're like, I don't understand how these surg techs know what happens next. It just comes with time. But that's why we need to understand these things. If you can make note of, okay, this particular break on this X-ray means I need this set of instruments, you can plan ahead for those things. Okay. So here are some other diagnostic tools. These are your imaging techniques. So standard X-ray, I think most of us are probably relatively familiar with what an X-ray is. It provides a picture based on gamma radiation. So here are some of the uses. It's actually got quite a bit of uses. Orthopedics is very common, like that previous image that let you see that broken bone. It can also be used to see biliary structures. A biliary structure is going to be anything that pertains to the liver going in the tubes, the ducts going to the gallbladder, the pancreas, and then into the small intestine. So things like your gallbladder, common bile duct, hepatic duct, those are all part of the biliary tree. There can be a lot of issues with that pertaining to stones or blockages that we need a good picture of. So X-ray and types of X-rays will help see that. Vascular, we need to see if there's any maybe narrowing of the arteries or ballooning, like an aneurysm. Those will identify on an X-ray. Also can be used to verify surgical counts. So in each surgical procedure, you as a surg tech are responsible for making sure all of your supplies and instruments are accounted for. So in an ideal world, you will count all of your laps, Ratex, needles, sharps, all of those things need to get counted at the beginning of the procedure before the patient ever enters the room. That allows for you to have a base initial count. You know what you started with, which means if you add anything to it, you can add to that number, and you should know what you end with, right? In emergency procedures, sometimes the initial count can be omitted just because you don't have time. The patient's life is on the line. You can't necessarily count everything. So what you can do at the end of those particular cases is bring in a portable X-ray machine, because they can be portable or fixed. Bring in a portable X-ray machine at the very end and take images of the area in which you were working to see if maybe anything got left behind. It does happen, unfortunately, but ideally you would do your initial count. Some precautions you should be taking with standard X-rays. It does use a type of radiation that can, over time, be very damaging to our body tissue, especially things like your thyroid and your reproductive organs are most susceptible to being injured. So we try to shield those, especially those areas. You can use a thyroid shield that is lead, as well as an entire lead apron. So that's part of your shielding. Remember, time, distance, and shielding are the three things you need for precautions for standard X-ray. So the time of exposure you want to limit, and distance to at least 6 feet is ideal. That's going to minimize your radiation exposure. So then you have fluoroscopy. And two types of fluoroscopy include a C arm and an O arm. They are shaped like the letter C and O, okay? Remember, fluoro is used to see real-time picture. It's live, okay? So I kind of tried to put the image here as it correlates. So this is a type of standard X-ray. There's a couple variations of these. This is a type of C-arm machine. It does raise and lower, and this part can like rotate side to side to get whatever, angle the surgeon might need. And so it is portable. It comes in, slides in over top of the area that the patient is laying in or however they're positioned. And then if it's over our sterile field, we will also place a sterile drape over the C arm or O arm. Okay. So for real time, it's very good in ortho. If we're trying to like realign a fracture, a broken arm or whatever, the surgeon wants to make sure that's perfectly aligned, even though they may have it open, or they could be doing it as a closed reduction. They want to make sure that bone's realigned properly, or even when they're putting in screws, making sure the screw doesn't go too far out the other side of the bone, anything like that. So it can be used in real time as the surgeon is, drilling in that screw. Vascular, we want to make sure there aren't any blood clots or leakages or blockages. Biliary, like I mentioned before. And GU, it stands for genitourinary. So these are going to be things used for looking into the bladder up the ureters and into the kidney. So if they suspect maybe there's a kidney stone, we want to see if there's a blockage. We can use something called contrast media, which I mentioned up here as well. Contrast can be used with really any of these, but it helps visualize structures because contrast media isn't going to let the image of the x-ray pass through it. So it highlights it really well. So if it shows up, you push this through the ureter and then, as it's being pushed through it, it no longer goes any further. You can see that it stops on that x-ray. There's a blockage, maybe from a stone if you're in the ureter or kidney. So then the surgeon can then make that adjustment. You can even see this as a surg tech on the screen. You'll be able to see the screen while they're doing this type of contrast with fluoro, C-arm, whatever, and you see that blockage. So in your head, you're thinking, okay, now what do I need because there's a blockage? Do I need maybe some sort of stone basket removal? Do I need a stent? Do I need, anything specific to the case that I'm working in? Do I need those things? Because now I see that there's something wrong. So that's an example of how you can start to think as a surg tech. You want to try to stay like 1 to 2 steps ahead of your surgeon at all times, which is hard to do. But knowing these types of little things, as far as diagnosis and pathology are concerned, will really make you a valuable asset to that surgeon and that patient by being able to, anticipate that type of need. Okay. So again, the precautions over here are going to be pretty much the same as standard x-ray, but I did make note that the O-arm, which is kind of a newer tool, so to speak, within the last 5-10 years, is far more powerful than the C-arm. So you really want to make sure that you take your precautions seriously there. One thing I also forgot to put up here actually for precautions is a lot of places require you to wear what's called a dosimeter badge. It's a little badge that you have to wear at all times when you're working that measures the amount of radiation you're exposed to in a given period of time. And then you'll have to send that badge in and they'll read it and say, okay, you've been exposed to so much radiation. If it's too high, they may have to stop you from going in those cases for a while for your own safety. So CT scans, or CT stands for computed tomography. It's really good for seeing things like vascular bleeds as they're happening. Like if you have a trauma patient come in and they suspect that there's bleeding on the brain, it'll allow to see that very quickly. So it's good for assessing ducts and blood vessels. GI system is your gastrointestinal system. So seeing all the internal organs, really precise tissue differentiation. The last one here is MRI, which stands for magnetic resonance imaging. So it's a little bit different than the standard X-ray in that it uses a radio frequency with a really strong magnetic field to produce high-def images. So it's really good for detecting abnormal structures or tumors in like a real, it could be 2D, but it's usually 3D image, so they can see all the way around it. The caution or precaution here is that because it's a very strong magnetic field, you don't want any metal in that room at all, because once that machine is turned on, it will literally suck in any metal to that machine. And then basically you have to call the manufacturer and spend hundreds of thousands of dollars to fix it. So, and it can damage or injure the patient if the patient's in there. So you don't want any metals. We always, always verify with the patient if they have any metal on them, no earrings, no pacemakers, even some vascular clips used to be a little bit more magnetic. And old school tattoos, I think the newer ones are not as much of an issue because they've kind of removed some of those metals, but old school tattoos used to actually have metals in them. So these two actually look very similar, but they are a little different. So I wanted to just show you a quick clip of how a C-arm could be used in surgery. Like I said, the possibilities are far greater than what this video shows, but it gives you an example of how this surgeon uses it in orthopedics, like I had mentioned before. So I want you to pay attention to not only what the C-arm is used for, but I want you to look at what's happening in the room, and maybe try to pick out what the surge tech is doing, how, the image is portrayed on the screen. Just kind of try to take it all in. Okay, it's not a very long video, but just try to take those things into consideration.
I am an orthopedic surgeon and specialty trained in joint replacement surgeries, mainly.
I will stop right here. I hate to stop these videos, but when I first watched this, I'm like, wait, what is the surgeon doing? Are we watching Grey's Anatomy? Because he's coming in without a mask on, which really I don't love. But the reason why he's doing it is because you see these surge techs are wearing what's called a hood. In orthopedics, especially joint replacement procedures, they'll wear extra protection for the patient and for the staff to minimize SSIs. But once they put this hood on, they don't have to wear a mask inside of it because they're covered. But a lot of places will still wear a mask in. They'll just pull the mask down, once they've gotten it put on. But I just wanted to point that out so you weren't thinking this was some, crazy video.
Of the hip and knee. I have been most impressed with the Philips Zenition in terms of the benefits I've seen with regards to image quality, ease of use, and the ability it gives me to use intraoperative technology during my surgeries. The preset and different anatomical settings allow us to be able to utilize the C-arm without a lot of adjustments to improve efficiency during the case. We may get into situations where patients have thicker anatomy, have previous existing implants, and other things that may obscure our imaging. The MetalSmart and BodySmart capabilities allows for correction of parallax right in the immediate field of view so that we don't have to worry about distortion at the image edges. The simple feature within the Radling system to stitch images together can really provide a surgeon with a single picture from multiple fluoroscopic images together all at one time. In orthopedics, the use of fluoroscopy happens multiple times a day, multiple days a week, so the additive effects of radiation is important. Anything that can decrease that, whether it's a low-dose setting like the Zenition has, or the ability to capture those images the right way the first time, is a safety factor that I and every orthopedic surgeon thinks about. The Zenition offers me ease of use. Even I, as a surgeon, can direct the movement of the C-arm due to the counterbalance capability, where the tech can leave everything unlocked and I can easily maneuver it into place on my own from the operative field. I can focus on what I'm doing without having to direct the image capture and change the images on the fly, because the ease of the interface makes it so that pretty much anybody that has come into my operating room can immediately access the C-arm, direct the C-arm, utilize the C-arm, and does not need really a lot of added direction. Its small footprint and the ability for the C-arm to not take up a large area within the OR that we're trying to keep sterile is something that's really been a benefit. The simplicity of having the Radling system built into the C-arm itself is a game changer that allows me to view the images and what's happening on the Radlink without any tech or rep being in my field of view. I've used a lot of different C-arms in kind of the course of my career. Philips Zenition specifically has provided me with better efficiency, better image quality, better surgical outcomes, and better knowledge of exactly what's happening during the case and after the case. It's been good for my institution, it's been good for my staff, and most importantly, it's been good for my patients.
Okay, so hopefully that kind of gives you an idea of how a C-arm can be used in surgery, specifically the orthopedics. You got to see, real time that picture of how that implant was being put into that hip. So you'll learn some anatomy and you'll understand, okay, that's, what you're looking at on the screen. You can make adjustments as a surge tech, even before the surgeon says it if need be. So that does come with time. Hopefully you noticed everybody else in the room and kind of what they were doing. Notice that they all had X-ray lead apron on to protect themselves. A lot of them did have the thyroid collar on. You'll see some people that don't use it, but they really should, unless they've already had their thyroid removed. Then obviously you don't need it. They did wear that dosimeter badge to keep track of their dosage. Okay, so hopefully that gives you a good little indicator of how it could be used if you've never seen that before. Okay, and this next one I wanted to show you was how a fluoro could be used in like vascular. So this one is about an angioplasty. It does give you a little bit more of like the steps of an angioplasty in general, but it shows you how we can use that contrast media, which is something that they can inject into a vessel in this case, and again, watch the flow, see if there's any obstructions, etc., or leakages. It would show a lot of things. But this is a pretty common procedure that you might end up doing as a surg tech. So watch this one.
This animation is brought to you by Skillshare, an online learning community with thousands of inspiring classes for creative people. Explore new skills, deepen existing passions, and get lost in creativity.
A coronary angioplasty procedure is also known as percutaneous coronary intervention. The procedure is done on blood vessels called coronary arteries. They supply your heart muscle with oxygen. The goal is to restore blood flow if a substance called plaque has significantly narrowed these vessels. To begin the procedure, the doctor will numb the skin in your groin. A needle will be placed through your skin and into the femoral artery. Next, a flexible guide wire will be passed through the needle into your artery. Then, the needle will be withdrawn. It will be exchanged for a small, flexible tube called a sheath. This permits access into your artery. You may feel pressure when the doctor inserts the sheath, but you will not feel it moving inside your artery. Next, the guide wire will be advanced up to your heart. A flexible tube, called a catheter, will be advanced over the wire to your coronary arteries. The progress of the procedure will be checked with an X-ray device called a fluoroscope. At this point, your doctor will remove the guide wire. Then, the doctor will move the tip of the catheter just inside the coronary artery to be examined. A special dye will be injected into the artery. This allows your doctor to view it better with the fluoroscope. The dye will make any blockages in the artery stand out. If a significant blockage is found, your doctor will insert a guide wire into the artery. A balloon on the tip of the catheter will be moved along the wire to the blockage. When the balloon inflates, it will expand the artery and improve the blood flow. You may feel some chest discomfort while this is happening. After this, your doctor will deflate and remove the balloon. A wire mesh tube, called a stent, may be placed in the treated area. The stent helps keep the coronary artery open. Your doctor will choose the proper size stent, which is compressed over a balloon. The stent will be moved into the artery over the same guide wire. When the balloon is inflated, the stent will expand and lock into place. After the balloon catheter is taken out, the stent will stay in place to hold the artery open. At the end of the procedure, the guide wire will be removed. To find out more about coronary artery angioplasty, talk to your healthcare provider.
Hopefully that gives you a better image of what we're talking about when we're doing vessels with fluoroscopy and angiograms, arteriograms. Using that contrast especially is so important. And notice, maybe you didn't pick up on it, but they refer to that contrast as a dye. That's actually kind of a misnomer in that it's not really a dye, but some people use those terms interchangeably. Contrast media and dye are not the same thing. I just wanted to point that out to you. It's kind of a pet peeve of mine. Dye is something that is used to color tissue to differentiate the different types of tissue so you can remove it. Contrast is used to highlight a picture on an image like a fluoroscopy. Just wanted to point that out to you. It's a pet peeve of mine. All right, so now on to monitoring vital signs. While as surg techs, we are not typically responsible for monitoring vital signs, we can pick up on these things as they're being monitored and adjust accordingly, especially if we see the patient's oxygen saturation is dropping in the middle of the case, that might indicate that there's something wrong. We have to maybe take emergency action. It's good to know what the norms are, so you would know if something's out of ordinary. There are some procedures in which they're done under local and the patient is awake, and maybe even anesthesia isn't even in the room because they're not being put to sleep. That does happen sometimes for minor procedures. So typically the circulating nurse will be responsible for monitoring vital signs, but having you as an extra set of eyes or even ears is going to be important for that patient care. We can also help put on some of these things. Like if you're free in the room and not scrubbed in, you can be available to put on the blood pressure cuff. You need to know where those go. You can be available to put on EKG leads. I've done this lots of times if your anesthesiologist will let you. You can put on the pulse ox monitor. So just be aware of those types of things that you can help with those things, even though you're not particularly in charge of monitoring their vital signs. So pulse should be between 60 to 100 beats per minute in an adult. If you were to, check it, you find your pulse points on the wrist is a really good one. You could do the neck, you could do the brachial artery, but take your first 3 fingers, not your thumb, and press gently. You don't want to completely depress the artery, but just press gently and count while you're watching a stopwatch or something for 30 seconds, and then multiply it by 2. That will give you how many beats per minute. So 60 to 100 is pretty normal in an adult. 100 is getting a little high, but it's anywhere from 60 to 100. And if you're like a really well-trained athlete, 50 is perfectly normal too. Respirations is anywhere from 10 to 12 breaths in and out per minute in an adult. And then blood pressure is usually between 120, 125-ish, over 75. So this top number is the systolic number, and the bottom number is the diastolic number. So the top number represents when the heart is contracting and there's pressure on those vessel walls. And then the bottom number is the relaxation phase, when there is no pressure or less pressure on the vessel walls. The best place to put a blood pressure cuff, which is called this really long, funny word, sphygmomanometer. I think sphygmomanometer. I think I had it backwards. It's usually most likely placed on the upper arm, which is going to be over the brachial artery. Now, if for some reason you can't put it on the arm, the thigh is acceptable, but you have to make sure that you have the appropriate blood pressure cuff for that patient. There is not just a one-size-fits-all blood pressure cuff. If you have a very large patient, you have to get the appropriate size blood pressure cuff. Like obviously that one's not going to work for pediatric, 4-year-old patient. So they do have different sizes. So I just put a picture here of how that would look on the patient. Old school, you would also use a stethoscope to check the blood pressure. Now a lot of it's digital, but you can still check it old school by listening to the when the sound of the blood stops flowing and when it returns. Okay, oxygen saturation should be about 98% or higher. That is measured the amount of oxygen that is being held on the red blood cells in the circulating blood. When it starts to fall below 77, 6-ish, they're going to start to try to figure out what's causing this drop in oxygen, and may even supplement with more oxygen. Okay, so you can place a an oxygen saturation monitor. We call it an O2 sat. Usually it's like a little clip type thing, or it could be a sticker if it's an infant, but it's usually put on the finger with that little light on it. Could be toes, could even be an earlobe if need be. And then the ECG, or it used to be called EKG, electrocardiogram, measures the heart conductivity, because your heart beats by an electric impulse. So it's measuring that electric impulse each cardiac cycle, which is the contraction and the relaxation phase each time, okay? So they do that by placing these electrodes in certain areas, because the heart electrical signal starts at the top of the heart and travels downward. So this allows it to get a very good picture of what's happening on the heart. So they are color coded. The monitors, those are those stickers that get placed on the outside of the patient's chest. They are color coded. Sometimes they'll use a 5 lead, which is this one here, 5 lead EKG. Sometimes it's 3. In more serious instances, they will use a 12 lead EKG, which gives an even better picture. We as surg techs typically don't read EKG monitors. I know some facilities will let you if you've been trained to do so, but in my however many years, let's see, so 10, 14, almost 14 years, I have never, or any of my fellow surg techs have had to read an EKG monitor. So it might just depend on your facility if they would train you and let you do that. But I've never had to do it. I have, however, had to put on the leads as helping out my anesthesiologist. So again, anytime you're free in the room and you're not scrubbed in or sterile, you need to be up at that patient near anesthesia to help them with anything they might need. Obviously, you cannot push meds. You still have to work within your scope of practice, but this is within your scope of practice. You can put on EKG leads if they direct you to do so. So the 3 I can remember as far as like a saying goes is smoke over fire and then white on right. That's the easiest way I can remember it. So for the 3 lead, so this one's black, this one's red, and then the white is on the right side. So these 2 are on the left. And then if they require any others you're not sure of, just ask. They would be more than happy to tell you. All right, so moving on to tissue examination. So again, with pathology, a pathology is anything that strays from normal. You've got your abnormal anatomy at this point. So we want to make sure that we're checking pathology for abnormal cells, anything that could lead to cancer. That's what this is pertaining to. So these types of biopsies, tissue biopsies, are super important because if you mishandle any of these, it could honestly, it could delay not just the treatment, but it could impact the patient in a way that could lead to death because you could delay their course of treatment. So if this excision or biopsy, whatever, turned out to be cancerous and you didn't handle it correctly or whatever happened, you didn't know what you were doing, you could delay that person's treatment. Maybe it was for cancer, which could eventually lead to death. So it is super important to understand why we're doing these, what they mean, and how to handle that particular type of tissue. It is so important. So some terms here related to tissue biopsy. One of them is excision. If you excise something, you're taking it out. So it's a surgical removal of a portion of tissue. It could be done in several ways. So one of them is like a needle biopsy, where it's usually a pretty long needle. It's got a hollow core inside that needle, and it is used to remove just like that core sample of tissue that would go maybe into a tumor and pull it out. So whatever was in that hollow needle is your sample. Then you have a brush biopsy. This can be done if you're doing maybe an EGD or maybe in the lungs, and they want to, brush up against the hollow tube of maybe the bronchi or whatever to see the cells on that lining. They can use a brush. We'll brush the sides, for the cells, and then you're going to swish that brush into a liquid preservative. Now, some facilities will even make you cut off the tip of the brush and send that for a specimen as well, just to be double sure. And then this one here, a frozen section, is a particular type that it's referring to a way in which you're going to send it to the lab. So a frozen section, we're going to take an excision biopsy, a piece of tissue, whether it's a mole that we think is cancerous, whatever. We're going to take that, put it in a dry specimen cup with no preservative in it, and immediately send it to the lab. Now that pathologist in the lab will look at it right away, and they're going to do that by placing it in liquid nitrogen, which will instantly freeze it like a flash freeze essentially. And then they have a machine that will slice it microscopically. Then they can view those cells under the microscope. It gives us a more immediate diagnosis of what is happening in that particular biopsy we just took, and we can adjust our course of treatment right then. We wouldn't have to wait, 7 to 10 days to get a lab result back just to show that, there's still cancer in the entire specimen and we need to take more. So a frozen section is really good for an immediate diagnosis. So for example, I used to do these a lot with one of our surgeons. We would take a mole, like a squamous cell carcinoma, off of the face or whatever. I think this one here is a nose. This is a good example of what that would be. So the surgeon has made this mark as to where, that outlines the margins that they want to take. They'll cut that out and send it to the lab immediately for frozen. And it takes about 15, 20 minutes usually for the whole process, and the pathologist will call back and say, this right lateral margin still has cancer all the way to the edge. They can see that under that microscope. So what they're then going to do, my surgeon, is then going to take an extra sliver on that margin that they said was still cancerous, and again send that for frozen. And maybe this one comes back, okay, that margin is clear. There are no more cancer cells. That way we know we've got it all. And the patient can move on with their healing or whatever treatment comes next. So it's pretty cool. But key here for us as search techs is making sure you send a frozen section to pathology dry. Don't put any saline on it. Don't put any fixative solution on it. I guess you can put a little bit of saline on it just so it doesn't dry out in the process, but you don't want to submerge it, and you don't want to put like formalin or anything like that on it. It will ruin the potential for a frozen section, which will delay their course of treatment. Okay, so hopefully this was beneficial to you in those diagnostic tools that we're going to use a lot. You'll see those a ton of times in surgery, right? So if you have any questions for me, please feel free to reach out. A lot of you have been sending me emails saying, hey, you know what, I've been in the hospital all week or whatever it is. Just give me a heads up on those things so I understand what's happening with you. If you need to reach out, here's my email. Office hours are today. But again, if you need to set up something else, we can work something out, okay? Remember, you're halfway there, so it's hard to believe we're already halfway through this quarter. So keep up the good work. You guys are doing a good job, okay? All right, well, have a good week. Bye.